Alright guys, let's get busy talking about prostate adenocarcinoma, also known generally as prostate cancer. In this video, I really want you guys to focus on the comparisons and the differences of prostate cancer with benign prostate hyperplasia. Prostate cancer is largely going to affect our men in ages 50s, 60s, and 70s, and the symptom profile is going to be very similar to our men presenting with BPH. Same age, same urinary type symptoms, and so I really want you guys to focus on creating a differential and how to separate these two on exam day. And to help you out, I'm going to highlight everything that's specific to prostate adenocarcinoma in this red color, and then where there's overlap between prostate adenocarcinoma and benign prostate hyperplasia, I'm going to highlight it in green. That way you can start forming differentials in your mind and starting to approach these questions by finding ways to differentiate the two. So let's go ahead and get started by talking about the physiology and the pathophysiology of prostate cancer. So if we zoom in here, here's the prostate, and essentially in prostate cancer, we have a neoplasm of the glandular tissue. It's more likely to show up in the posterior region of the prostate as well as the lateral region of the prostate. And essentially, similar to BPH, there's going to be a real estate effect. So we're going to have encroachment of the urethra, which I have here from the anterior posterior view, and then the lateral view here, and it's going to obstruct urine from flowing out of the urethra. So usually the presenting symptom is going to be some type of urinary complaint, very similar to BPH, either trouble initiating urine, trouble ending a void, feeling like the bladder is constantly full. And this is because urine is constantly being pushed back up into the bladder. This can cause detrusor muscle hypertrophy, which we can show here in this green color. The detrusor muscle is going to get really big because it's constantly pushing against an obstruction. And now I want to talk about a specific difference between benign prostate hyperplasia, which is a benign process, and prostate cancer, which can be malignant and metastasized. So let's draw in some more anatomy here. Here is our spinal column. I'm drawing these boxes as the vertebrae, and you'll see that it sits right behind the prostate and the bladder. And there's a venous plexus that actually connects between the prostate, the bladder, and the spine. And this venous plexus shares blood between the spine and these areas. And so in prostate cancer, we can get metastases, which I'm showing with these red dots, that are going to travel through that venous plexus, and they can come to metastasize to the spine. And so this brings us to the classic presentation of our patient with prostate cancer that has advanced to metastasis. They're going to present usually after a fall. It's going to be a 50 to 70-year-old male who's complaining of back pain after a fall that's out of proportion to what you would expect. And you're going to get imaging of this patient, and you'll see that there are going to be metastatic lesions. I'm going to circle these here. You can see these dots that are not supposed to be here. These are all examples of prostate cancer that have metastasized to the spine. So let's kind of go over the pathophys all from the beginning again. This is a malignancy arising from prostatic glandular tissue. Complications that are going to be similar between BPH and prostate cancer are going to be bladder distension and hypertrophy, hydronephrosis, and UTIs. However, the differentiating factor is going to be our metastasis to the spine via the vertebral venous plexus that we talked about. In terms of our age groups, both BPH and prostate cancer are going to have increased incidence with increased age. So we're looking around age 65 to start seeing this condition. However, in prostate cancer, we're going to expect it to be more common in Black men, and this is not a feature on exam day you would expect to see in BPH. Let's move on to reviewing the presentation, which we kind of got at already. Let's start by highlighting some of our similarities. So it can be mostly asymptomatic with the exception of those urinary symptoms similar to BPH. So the signs of obstruction that are going to be similar between the two are going to be dysuria, UTIs, or a post-renal AKI. However, when you get this collection of symptoms, these urinary symptoms in a 60, 70, 80-year-old male, this is when it's going to be time to do your digital rectal exam. This is the key piece of the physical exam that is going to differentiate these two disease processes for you. So in prostate cancer, it's going to be a nodular, asymmetric, and indurated prostate on digital rectal exam. This is as opposed to BPH, where we expect a symmetric, really smooth prostate. So these are going to be very different in how they read on exam day, and this is a key differentiating point. And then additionally, we talked about the metastasis, which can cause back or bone pain. This is going to be super high yield on exam day. I really want you guys to be aware of the fact that this type of cancer classically metastasizes to the back. So now that we've talked about how to identify and diagnose diagnose this on exam day. Let's move on to some of the diagnostic qualities of this cancer, and this is where they're going to hit you with third order questions, likely up down arrows based on lab values. This is where it's going to be a tricky third order question. I want you guys to nail it on exam day. So let's start out by talking about increased levels of prostate specific antigen, also called PSA. This is going to be increased in both BPH and in prostate cancer. However, we are able to differentiate these two based on the relative levels of bound and unbound PSA. So let's go over that here. You'll see that here I have PSA in orange bound to a carrier protein in the blood, and then I also have PSA that is just free floating in the blood. And we can actually measure the differences in these two forms of PSA, and this allows us to differentiate BPH and prostate cancer. So in prostate cancer, we're going to expect a decreased fraction of free PSA. So essentially, we're going to have more PSA existing in the bound form when we're talking about prostate cancer. That's going to be a key lab value in an up-down arrow question that can help you differentiate. Let's move on to our next lab value with increased alkaline phosphatase. And the reason why this is increased is because of the bony metastasis. Alkaline phosphatase is a signal, is a lab marker of bone turnover, and we have osteoblastic bony metastases in prostate cancer. And I want to emphasize the fact that these are osteoblastic bony metastases. This is as opposed to multiple myeloma, where we can expect to see osteoclastic with a C, and that's going to be an elderly gentleman usually also presenting with back pain. So it's important to look for signs of osteoblastic activity versus osteoclastic activity suggested to you in a question stem. That's really, really high yield to know that osteoblastic is referring to prostate cancer here. Lab values that are going to reflect a post-renal AKI. This is going to be defined by increased BUN, increased creatinine, and a BUN to creatinine ratio of less than 20. And this can happen in both BPH and prostate cancer because they're both obstructing. They're both causing urinary backflow up into the bladder and up into either kidney. And so this is why we're going to see a post-renal AKI picture in both of these, which is why I highlighted it in green for you guys. Diagnostic piece of information is going to be the biopsy, which is measured using a Gleason scale, which is a fancy tumor staging system. This is relatively low yield. It's highly, highly, highly unlikely that you guys would ever be asked to operationalize a Gleason scale and stage a tumor. I just wanted you guys to be aware that this is the process of the management to prostate cancer. Now to talking about our management of our patients with prostate cancer, the management is going to be really variable, and this is because prostate cancer tends to be a really slowly progressing cancer, and it tends to show up later in life, so in the 60s, in the 70s. And so if a prostate cancer is going to be really slow and a patient doesn't get it till age 75 or 80, they may decide that they don't want to treat it. They might not want surgery. They may not want medications that are going to have side effects. And so usually this is a shared decision-making process with the patient based on what their goals of care are. And this is because the pharmacologic methods we have for treating prostate cancer have pretty intense side effect profiles because they affect hormones. Prostate tissue is a hormone-sensitive tissue, and so all of our pharmacologic modalities are going to be addressing hormones. So let's go ahead and break these down one by one. We're going to start with our androgen deprivation therapies, and these are all going to be related to our hormones. So these are going to be all these that I'm highlighting here in orange. Let's start out by talking about our GnRH analogs, which are going to be leuprolide, goserelin, nafarelin, and histrelin. The most classic one that I see on exam day is going to be leuprolide. That is going to be your classic treatment of prostate cancer. And let's talk about some of the physiology and how this medication works. So if we zoom in here to our picture of the hypothalamus and the pituitary gland, I went ahead and transposed a little graph here onto our HPA axis. Here on the x-axis is going to be time, and then here on the y-axis is going to be levels of GnRH. And I put it in quotations because leuprolide is like an artificial GnRH. So we're looking at levels of GnRH agonism. So in the normal individual, in the normal physiology of a male, we're going to look at levels of GnRH. And normally this is going to be pulsatile levels. So it's going to get really high and then it's going to come down. It's going to get really high and it's going to come down. It's going to get really high and it's going to come down. This is the classic physiologic level of GnRH secretion in a normal male. And I'm going to highlight the area under the curve here to show you what this GnRH secretion pattern looks like. Let's change this to reflect leuprolide. So in leuprolide, we actually give a continuous level of GnRH agonism. So I'm drawing like this continuous level all the way up here, and you can see that the area under the curve here is much, much bigger. So we're giving constant stimulation of GnRH through leuprolide when we are treating prostate cancer. And essentially this continuous agonism that we get with leuprolide therapy is going to shut off the pituitary gland from releasing FSH and LH down here. So normally our GnRH pulsatilely will encourage flow of FSH and LH out of the pituitary. However, when we give constant stimulation like this in the form of leuprolide, this is going to cut off all stimulation of FSH and LH production in the pituitary, and this is how leuprolide and other GnRH agonists work to treat prostate cancer. I think this is really fascinating physiology, and they like to ask about this on exam day, so I want you guys to be aware of it. Now to talking about flutamide, and flutamide, also bicalutamide, is going to be competitive inhibition at androgen receptors. So essentially they're going to go to the androgen receptors in the prostate, and they're going to block agonism from any androgens. I think the classic one here as flutamide that shows up most common on exam day. And then finally, we have ketoconazole, which is going to be a 17-alpha hydroxylase inhibitor. This is going to decrease the amount of steroid hormone production. And when we have less production, we're going to have less agonism at the prostate, and the cancer is going to grow slower. And then finally, these patients are also eligible for radiation and chemotherapy. This is going to be shared decision making. You're not going to be really asked too much about when chemo or radiation is indicated on exam day, but just know that this is an option or maybe part of a patient's medical history who has prostate cancer. And then, like I said, the important things in our differential is going to be benign prostate hyperplasia, and we differentiated these using our lime green and our red highlighting being the things specific to prostate cancer, and the lime green being the things that are shared between BPH and prostate cancer. So I would say the most important thing for you guys is to go back and review the similarities and differences between prostate cancer and BPH. If you do that, you should be ready to nail these questions on test day. I hope you guys enjoyed all this content on male pathology. Can't wait to see you guys in the next videos. Bye!